normally, but there's obstruction within the liver itself. So there may be an intrahepatic obstruction. Something blocking the small bile ducts in the liver before the bile is able to get down to the right and left hepatic duct and the common bile duct and the gallbladder and all the rest of that biliary system. So hepatic, failure of the liver cells themselves, or some obstruction inside the liver. Now the posthepatic type may be due to obstruction of the bile ducts themselves, where there is some blockage actually in the bile ducts themselves. Or alternatively, bile might not be able to get through the bile ducts, not because there's a blockage in the bile ducts themselves, but because there's pressure on the bile ducts from outside structures. So if there's an abnormality in the region of the bile ducts, such as a tumour pressing on the bile ducts. So that's a basic classification of the causes of jaundice. But there's one area which sometimes causes confusion. Some books and some authorities refer to jaundice as being a cholestatic jaundice. This means where there's an obstruction to the flow of bile. So I've classified it as prehepatic, hepatic or posthepatic, but others refer to jaundice as being cholestatic jaundice. Now what does this actually mean? Well, cholestatic means that there's a stasis of the flow of bile, that for some reason the bile is being produced but is not able to get out of the liver or the bile ducts. But I think if you actually look at this diagram, it'll make sense if you draw something around it like this. So these first two are not caused by stasis of bile. This is not caused by stasis of bile. But if there's an obstruction inside the liver itself, then that is. That's caused by obstruction of bile. And these two are both clearly caused by obstruction of bile. So these are sometimes referred to as cholestatic jaundice. Cholestatic. So cholestatic jaundice is where the bile is produced, but for some reason there's an obstruction. The obstruction may be in the liver, may be in the bile ducts, or due to pressure from outside the bile ducts. So the three types of cholestatic jaundice. So cholestatic jaundice may be hepatic if it's due to obstruction, or more commonly it would be posthepatic. So we've said jaundice can be a result of increased hemolysis, reduced capacity of the liver to remove the bilirubin from the blood, or a blockage of the bile ducts. But there's another type of jaundice which can be physiologically. Shortly after birth, babies break down a lot of the fetal red blood cells, and this can give rise to a physiological jaundice, which can be quite normal, depending on the severity of it, but it can be quite normal. But this isn't to be confused with another condition which can give rise to jaundice, so-called hemolytic disease of the newborn, which is due to rhesus factor incompatibility, which we discussed when we looked at blood groups and the fact that you can have a rhesus negative mother and a rhesus positive baby. So let's just review these types of jaundice now on the notes, looking at prehepatic, hepatic and posthepatic. And then we'll go on and look at nursing care and management. So the types: increased hemolysis we've discussed, reduced capacity of the liver, which is hepatic, or blockage of the bile ducts. So really they're what we've described: prehepatic, hepatic, posthepatic. But remember, blockage of the bile ducts can be blockage within the liver itself causing a cholestatic jaundice, which by our classification would still be hepatic. Jaundice may be physiological, but only just after birth. But that's not to be confused with the very severe life-threatening condition of hemolytic disease of the newborn due to rhesus factor incompatibility. We'll now go on and look at these categories in slightly more detail. Firstly, we'll think about prehepatic jaundice. We've said it's caused usually by increased hemolysis. And typically, the patient is not a dark, severe jaundice. The jaundice tends to be fairly light. They tend to be a pale lemony colour. Now, they're a lemony colour because they're like a light yellow due to the increased amount of bilirubin in the blood. But if you think about it, in hemolytic disease, then the liver should be working normally. There's no reason why the liver should be abnormal. So the liver is able to get rid of quite a lot of the excess bile pigment that's produced fairly quickly. So although there's more bile pigment being produced due to the increased hemolysis, the liver is able to dispose of it quite quickly, so the jaundice tends to be mild. But these patients also tend to be pale in colour. And this is because there's an increased hemolysis. And if there's increased hemolysis, then clearly there's less red blood cells left in the circulation. So the oxygen carrying capacity of the blood will be reduced, and these patients tend to be anemic. And sometimes when you feel the upper right-hand side of the abdomen, the spleen's enlarged, because we said that the spleen is the main site where red blood cells are broken down. So because of the increased workload of the spleen, in some forms of hemolytic anemia, you get a splenomegaly. You get an enlarged spleen. Now, very often in obstructive jaundice, in cholestatic jaundice, the stools are a pale colour. But in prehepatic jaundice, then the bile is being produced in the usual way. The bile is able to go down the bile ducts in the usual way and enter the faeces in the usual way. So the stools actually appear normal. There may even be an increased coloration of the stools because there's an increased amount of pigment going into the faeces. So the stools normally appear normal, and there'll be urobilinogen in the urine as normal. And indeed, if anything, an increased amount of urobilinogen in the urine is normal. And the final feature that's sometimes associated with prehepatic jaundice, as well as the anemia, is that if you look at the blood, there's a lot of reticulocytes in the blood, young, immature red blood cells. And this is because the body increases hemolysis, increases hematogenesis. It increases the formation of red blood cells to try and account for the increased hemolysis. So the spleen may be enlarged, stools appear normal, urobilinogen in the urine as normal, and immature red blood cells on blood films. Next, we're thinking about hepatic jaundice. There's a problem in the liver. Either the liver cells aren't functioning properly, hepatocellular jaundice, or there's an obstruction to the small bile ducts, the canoniculi, actually in the liver itself, causing an obstructive jaundice. Both abnormalities in the liver causing hepatic jaundice. So hepatic jaundice may be hepatocellular. Here, normal levels of bilirubin are produced due to normal hemolysis, but these accumulate in the blood because the liver cells are unable to take them out of the blood and put them into the bile. This occurs in liver infections, liver cancers, primary liver cancers, hepatocellular carcinomas, as a result of some poisons and some drugs. Alternatively, if there's swelling in the liver, there's a swelling of the hepatocytes, the liver cells are swollen, and this is going to obstruct the small bile ducts. The canoniculi in the liver are going to be obstructed. These won't be able to deliver the bile to the right and the left common hepatic duct. So it's sometimes referred to, yes, it's obstructive, but it's in the liver. So it's intrahepatic obstructive jaundice. So intrahepatic, cholestatic, intrahepatic jaundice causes cholestasis. It's a cholestatic thing.